So let's begin our discussion with Hodgkin lymphoma. So both lymphomas are malignant process involving the lymphoreticular system. Okay, so there is a neoplastic transformation of the lymphocytes. Here in Hodgkin, predominantly the site is lymph node. So the neoplastic transformation of the lymphocytes predominantly occur in the lymph nodes. Hodgkin lymphoma has two peaks. One is at 15 to 35 years and another one after 50 years. So this is called as the bimodal age of distribution. Hodgkin lymphoma has a male predominance among children, but this male to female ratio actually becomes quite equal and as the age progresses. And this causes of Hodgkin lymphoma are some infectious agents, some viruses predispose or some viruses poses a risk for certain individuals to develop Hodgkin. One important virus is EBV. After that, you can remember HHV6 and CMV. So these are some of the infectious agents that are a risk for Hodgkin lymphoma. So this particular cell that you can see on the histopathology is something that we are very familiar with, something that we have been learning from our second year MBBS times. So what is this cell? This is the Reed-Sternberg cell of Hodgkin lymphoma. So if all the features we are talking about, if someone asks you two characteristic features that you have to name for Hodgkin, you are going to tell these two. One is of course the Reed-Sternberg cell. Another one is Hodgkin lymphoma always spread in an orderly fashion. It spreads contiguously to the lymph nodes. So that orderly fashion is something which is very, very characteristic of Hodgkin lymphoma. So what is this Reed-Sternberg cell? I will discuss in a while. So coming to the prevalence of Hodgkin. So 6% of childhood cancers is Hodgkin. So it is quite a rare phenomenon. Some of you wouldn't have seen in children. And as the age progresses, see between 15 to 19, the incidence increases. The 15% in persons between 15 to 19 years. It is quite rare in childhood. So we have learned the classification of Hodgkin lymphoma from pathology, right? And now there is a new WHO classification or the REA classification, REA, Revised European American classification. So either you can call it as a new WHO classification or the new REA classification. So what is new in this classification is that broadly it is divided into two. One is the nodular lymphocyte predominance, another is the classical Hodgkin lymphoma. So all these subtypes are going to come under your classical Hodgkin lymphoma, right? So remember, it is divided into broadly two, nodular lymphocyte predominance and another one is the classical Hodgkin lymphoma. So among this classical, you have four types: lymphocyte rich, lymphocyte depletion, nodular sclerosis and mixed cellularity. Okay, so this is the new WHO classification or the revised European American classification of for Hodgkin lymphoma. So nodular lymphocyte predominant type and classical Hodgkin lymphoma type. Among classical Hodgkin lymphoma, you have four subtypes. So let's discuss in brief about Reed-Sternberg cell. So this is the Reed-Sternberg cell that you can see over here. So what you can see, this is quite a large cell, somewhere between 15 to 45 microns, and it has multiple nuclei, at least two nuclei which are mirror images. Okay, so these are mirror imaged nuclei containing large cell is nothing but a Reed-Sternberg cell. This is a pathognomonic feature of Hodgkin lymphoma. But isn't it present in some other conditions also? Yes, it can be present in infectious mononucleosis, of course, which is caused by EBV virus. So this Epstein-Barr virus is going to cause infectious mononucleosis and this EBV is again going to predispose or it poses a risk factor for Hodgkin lymphoma. So it is present in infectious mononucleosis at times. It can be seen in non-Hodgkin lymphoma also. Where is this cell coming from? So this Reed-Sternberg cell, it originates from the germinal center B cells. So the B cells which are present in the germinal center of the lymph nodes progresses or it develops or modifies to form a Reed-Sternberg cell. But this does not have the CD markers which are seen in a mature B cell. No CD19, no CD20, 22. So it has lost all these B cell expression and B cell function. So this is nothing but a neoplastic transformation of a germinal center B cell. Usually this Reed-Sternberg cell will be surrounded by inflammatory infiltrate. There are many macrophages, eosinophils, plasma cells, normal lymphocytes, etc. So it is usually surrounded by an inflammatory infiltrate, and that depends on the subtype of HL. So if it is lymphocyte rich, it is surrounded by lymphocytes. If it is sclerotic type, it is surrounded by a sclerotic rim, something like that. So this is the brief discussion of a Reed-Sternberg cell.